Welcome to our primary care case presentation. Our patient comes in today with a chief complaint of abdominal pain, diarrhea, and fatigue. PG is a 68-year-old African-American female who presents with mild, intermittent, diffuse abdominal pain for the past several days. She reports that the pain is vague and dull and has become more frequent in the past 3 days. It is now present for half of her waking hours. She reports that the abdominal pain occurs unpredictably throughout the day without any aggravating factors, including defecation. She began taking ibuprofen 3 days ago, 400 milligrams every 6 hours, and reports it provides mild to moderate pain relief. There are no other relieving factors. She also reports diarrhea, which she states began 5 days ago and occurs an average of 3 times per day. Additionally, she reports persistent fatigue for the past 3 weeks. Her prior medical history is stage 1 hypertension diagnosed in 2018 and iron deficiency anemia diagnosed 2 months ago. Contrary to screening guidelines, she has not had a colonoscopy. She has 2 prior cesarean sections. Her mother had Alzheimer's disease and died at age 82. Her father had ulcerative colitis and colon cancer diagnosed at 71. He died at age 73. She has a brother with hypertension and type 2 diabetes and a son with hypertension. She takes hydrochlorothiazide and ferrous sulfate daily. She has no known allergies. She is a retired postal worker. She lives with her husband and has 2 adult children. She reports she eats beef at least 4 times weekly and aims for 1 serving of vegetables daily. She denies use of tobacco or illegal substances and reports that she drinks 3 5-ounce glasses of wine daily. For review of systems, constitutional, she's positive for fatigue and weight loss of 10 pounds, negative for changes in sleep and appetite. Another pertinent positive is her abdominal exam, positive for abdominal pain and diarrhea and increased defecation frequency, no noted melena or hematochezia. For physical examination, for general, she's in no acute distress, alert and oriented ×3. She's well-developed, well-nourished, and an overweight African-American female. Her vital signs are within normal range, aside from pulse, which is 102, and her pain score of 2 out of 10. No pertinent findings apart from her abdomen, soft, non-distended, mildly tender to touch on left, lower, and upper quadrants, no hepatosplenomegaly, hyperactive bowel sounds. And the pertinent negative is that there were no hemorrhoids or masses on digital palpation in the rectal exam. Additionally, she had pale conjunctiva for the heat exam.
So our overall assessment today of patient PG is she's a 68-year-old African-American female with a past medical history of iron deficiency anemia who presents today with abdominal pain, changes in bowel habits including diarrhea, fatigue, and weight loss. The patient denies blood in her stool. Significant social history findings include a high red meat consumption along with processed meat consumption, low vegetable intake, and high alcohol intake. Her significant family history includes colon cancer, and this patient has not had a screening colonoscopy. Significant physical exam findings include left lower quadrant and left upper quadrant tenderness, along with hyperactive bowel sounds. Our differential diagnoses for today's visit include 1, colorectal cancer, 2, diverticular disease, 3, inflammatory bowel disease, and 4, irritable bowel syndrome. So our plan for today's visit with patient PG, first up, we want to order a colonoscopy. Second, we want to order laboratory work. So we want to order a CBC, which is important to assess for iron deficiency anemia or anemia of chronic blood loss. And additionally, we want to order LFTs. We know that LFTs might, if they're elevated, indicate that there were metastasis of the colon cancer to the liver, if pertinent. Additionally, we want to educate the patient on healthy lifestyle habits, including moderate alcohol use, 1 drink per day for women, increasing dietary fiber of fruits and vegetables, decreasing dietary consumption of red and processed meat, and regular physical activity. Additionally, we will send a referral into gastroenterology for patient PG. So after colonoscopy, we determined that the diagnosis for patient PG is colon cancer. The epidemiology of colon cancer. We know that there are 135,430 new colon cancer cases as of 2017, 50,260 deaths. Colon cancer is the second leading cancer killer in the United States. Colon cancers actually affect men and women equally. However, rectal cancers are more common in men. There are higher rates of colon cancer among African Americans, and additionally, there is an increased incidence of colon cancer in Australia, New Zealand, Europe, and North America. We know that the survival rate is 66%, which is likely due to early detection and treatment of colon cancer, which is enhanced by screening guidelines. So risk factors of colon cancer. The first risk factor is age, which is the most important. We know that risk increases linearly with age, especially after 45 years. Colon cancer is rare in individuals younger than 35. The median age at diagnosis is 71 years. Additionally, we know that personal or family history of colorectal cancer or adenomatous polyps, and we know that this, with a first-degree family member, would increase the risk twofold with colorectal cancer. Additionally, hereditary syndromes, which most are autosomal dominant, are risk factors, and these include Lynch syndrome, breast, ovarian, and endometrial cancer, Peutz-Jeghers syndrome, and familial adenomatous polyposis. A history of abdominal pelvic radiation, inflammatory bowel disease, including ulcerative colitis and Crohn's, a diet high in fat, red meat, processed meats, and low in plant fiber, tobacco use, alcohol consumption, and obesity or overweight also increase the risk for colon cancer. So colon cancer signs and symptoms. We know that oftentimes colon cancer is asymptomatic and detected on a routine screening. However, some warning signs and symptoms include melena, bright red blood per rectum, changes in bowel habits, including constipation with intermittent diarrhea, ribbon-like stool or narrow, skinny stool, and abdominal pain, which is rare. Additionally, weight loss and anorexia are common signs of malignancy, and a physical exam may reveal a mass within the abdomen or an enlarged liver. Some protective factors for colon cancer. We note that regular physical activity, along with diet high in plant fiber, high intake of fruits and vegetables, and low in red meat consumption are protective factors, along with an increased intake of vitamin D, calcium, vitamin B6, folic acid, or folate. We know that the USPSTF actually recommends aspirin use for the primary prevention of colorectal cancer in average risk adults. And additionally, we note that NSAIDs is a protective factor for colon cancer.
Pathophysiology of colon cancer. The majority, about 95% of colon cancers begin as adenomas within the wall of the colon, so benign neoplasms of granular epithelial tissue, also known as polyps. These adenomas grow over about the course of 10 years, and they begin to show signs of dysplasia. Colon cancer is graded based on the type of histological change and staged by the amount of penetration. So stage 0 would be carcinoma in situ, whereas stage 4 would be distant metastasis. And about 20% of patients already have metastasis at the time of diagnosis.
Colorectal cancer screening recommendations may differ slightly depending on which guidelines are being used. The American College of Gastroenterology recommends that patients with average risk get a colonoscopy every 10 years, beginning at age 50. They also recommend that screening should begin earlier for African Americans at age 45. However, the American Cancer Society recommends regular screenings beginning at age 45 years old. They also recommend that patients who are between the ages of 76 and 85 years have the decision be left to the patient's preference, their life expectancy, overall health, and prior screening history. As far as the screening and diagnostic tests, colonoscopies are the most accurate and versatile diagnostic test for CRC and is considered the gold standard. However, not all patients are receptive to getting one, so fortunately there are some other options. A CT colonography is also available, however, must be done every 5 years and requires for the patient to drink a prep prior to imaging. Patients may also choose to have a flexible sigmoidoscopy. However, they must get this done every 5 years, provided their exam is normal. We must remember that this test only examines the lower part of the colon. There are other stool tests that are available, including the FIT test, which detects blood from the lower GI, and a fecal occult blood test, which detects blood from the entire GI. And lastly, there's a multi-target stool DNA test, also known as the Cologuard. It's important to assess for colorectal cancer at initial visit for an adult who is age 20 or older to assess whether they are average risk or higher risk. Some of the questions that providers should be asking include the following. Have you ever had CRC or an adenomatous polyp? Have any family members had colorectal cancer or a documented advanced polyp? If so, how many family members? Were they first-degree relatives? And at what age was the cancer or polyp first diagnosed? Do you have a family member with any of the known genetic syndromes that can cause CRC? Do you have IBD? And did you receive abdominal radiation for childhood cancer? What are the benefits of screening? Screening can improve disease prognosis by identifying early stage colorectal cancer, which is easier to treat and has a lower mortality rate than colorectal cancer detected after symptoms develop. Screening can prevent colorectal cancer by detecting and removing premalignant polyps before they progress to colorectal cancer. Progression from adenoma to carcinoma is believed to take an average of at least 10 years. Some issues in diagnosing colon cancer include with colonoscopy, cancers that arise from non-polypoid adenomas may be more difficult to visualize colonoscopically than polypoid lesions. Among asymptomatic patients, colonoscopy miss rates for colorectal cancer in the hands of experienced operators range from 2 to 6%. Missed cancers are most frequently on the right side of the colon. This brings me to my next point, the flexible sigmoidoscopy, which is not considered adequate to be a diagnostic study for patients suspected of having colorectal cancer. And that's because it's only imaging the lower parts of the colon and missing the transverse and the ascending colon. And lastly, for the CT colonography, this also requires a mechanical bowel preparation, which may be one of the reasons why a patient may have not wanted a colonoscopy to begin with. With this CT colonography, abnormal results should still be followed up with the colonoscopy for excision and tissue diagnosis. And lastly, this will also provide or give the patient a lot of radiation exposure as well.
So the management of colon cancer, we note that surgical resection is the only curative treatment for local regional colon cancer. Additionally, chemotherapy may be used as adjuvant chemotherapy in stages 3 and 4 colon cancer, and in some stage 2 colon cancers. And this regimen is 6 months done postoperatively in the outpatient setting. For general surveillance after a diagnosis of colon cancer and surgical resection, we schedule office visits for patients every 3 months, an annual CAT scan of the abdomen and pelvis, annual chest X-ray film for 3 years. A colonoscopy should be performed 3 months postoperatively and again at 1 year. If the results are within normal limits, we will follow up every 3 years with these patients. And then lastly, we have CEA levels that are monitored. And CEA levels are not a tool for diagnosis, but they're helpful for monitoring response to therapy, and an elevation in these levels may correlate with the reoccurrence of tumor or metastasis. So it's important to monitor in patients with a prior diagnosis of colon cancer. And lastly, these are the references that we used. Feel free to post any comments or questions in the discussion board. And that was our presentation on colorectal cancer.